Hello and good afternoon, everybody. Welcome to the conversation with Live on everyone's guide to know about colorectal cancer, organized by Voice of Healthcare and powered by Zydus Life Sciences. For this conversation on colorectal cancer awareness, with us, we have two very esteemed doctors today. Let me welcome Dr. Kakoli Lahkar, who is the consultant medical oncologist at Manipal Hospital, Old Airport Road, Bengaluru. Welcome, ma'am.
Hello, a very warm welcome to Dr. Manish also, and thank you for this opportunity.
Thank you. With us, we have Dr. Manish Sharma, who is the consultant and head unit of medical oncology at Rajiv Gandhi Cancer Institute, Niti Bagh, New Delhi. Welcome, sir.
Thank you so much. Good afternoon, all, and thank you for having me here on this show. Thank you.
So, moving forward, I'll hand it over to Dr. Kakoli to take it forward from here today. Thank you.
Thank you, Dr. Sawant. So, as Dr. Sawant has mentioned, so this is Colorectal Awareness Month, and this is a small attempt on our behalf to create some awareness and provide some insights into this disease. Now, for a brief outline, colorectal cancer is a significant health problem globally. So it is the third most common cancer among men and second most common cancer among women worldwide. Uh, and it ranks fourth among the cancers causing death. So it is the fourth most common cause of cancer-related deaths. See, 60% of the colorectal cancer burden is in the developed countries. However, we are fast catching up pace with them, and the incidence has been increasing in everywhere, even in India, even in developing countries. And one interesting fact is that actually in countries like India, it occurs at a relatively younger age, and there is also some indication that it might be more aggressive. As per the ICMR statistics, the annual incidence of colorectal cancer in India is around 4 per 100,000. There is something very interesting that it has been observed that around the world, the incidence of colorectal cancer has been decreasing, but that is mostly confined to the more than 65 years age group. The mortality has also increased. That means the risk of dying from colorectal cancer has also decreased, but that is primarily due to screening and better treatment modalities. However, it has been seen that in the relatively younger age group, the incidence is increasing. So it is just the reverse. So in fact, there is a projection, there is a very alarming projection that the incidence in the 20 to 34 age group might actually jump by almost up to 90% by 2030. So these are really alarming figures. So all this taken together, it only emphasizes the point that we should discuss about this, create awareness about this, and do what we can about this. Now, regarding the risks of colorectal cancer, I will just briefly outline what are the major risk factors. So 20% of colorectal cancers can be related to familial clustering. So some of these can be due to, known genetic syndromes. There are some syndromes like familial adenomatosis polyposis. So if somebody who has all these problems in the family is watching, they will understand what I'm talking about. So there are other diseases like hereditary non-polyposis colon cancer, Lynch syndrome. So these are very technical terms. But basically, if there are first degree relatives or second degree relatives who have had colorectal cancer, especially at younger age, then there is a chance that the concerned person might be carrying the gene. So age is one risk factor. So generally it occurs in age more than 50, but like I said, no age is immune. It can occur at any age. Then it is slightly more common in males compared to females, very, very slight male preponderance. Uh, then among other factors, among lifestyle related factors, we have the usual suspects: smoking, alcohol, obesity, more higher BMI, lack of physical exercise. These can contribute to colorectal cancer. Also, there is almost it is almost proven that decreased consumption of dietary fibers such as fruits and vegetables and increased consumption of red meat or processed meat can also increase the risk of colorectal cancer. Taking I mean, too much of it, I am not saying that somebody should totally avoid, but I mean, increased consumption. uh, Besides that, there are some there's something called inflammatory bowel disease. Okay, there's something called ulcerative colitis or Crohn's disease. So these can also increase the risk of colorectal cancer by to some extent. So basically, these are the major risk factors. Now, Dr. Manish, it is an immense pleasure to have you here on board with us. So I would like you to, highlight the main signs and symptoms of colorectal cancer.
Thank you, Dr. Kapli. So you very elaborately discussed about the epidemiology, and I think it is very, very important. So once we are talking about any kind of cancer, be it lung cancer, be it a colon cancer, be it a breast cancer, epidemiology is utmost important. And you very, very rightly said that it is the third most common cancer amongst men in males, and then it is it is in top five cancers in India as well. And very rightly you said that the mortality is increasing, and the younger patients, they are coming with CA colon nowadays. So we would not see so many young colorectal cancers a decade ago, or 2 decades ago. Definitely there is a shift from the older population to the younger population, and hence it becomes imperative, and ultimately it is a lethal disease if not detected early. So colorectal cancers, if they are confined to the bowel, or if they are just confined to the nodes, definitely it is a curable disease. But if it is, once it has gone beyond the nodes, and but once it has gone to the liver or lung, it is a lethal disease to have. So rightly said. And in this colorectal cancer month, that is month of March, this gives us immense pleasure that we are here talking about this and speaking to the people about this. So we go through any of the cancer, it is an important question in general public, that how do we recognize the early symptom of this disease. So very early when this cancer happens, actually it produces no symptoms. So most of the patients who are detected early in their course of the disease, they are screen detected cancer patients. So a patient undergoing a proper screening, undergoing either a colonoscopy or occult blood testing for colorectal cancers, they are those patients who are asymptomatic, and you don't know that they're any kind of cancer in those. So asymptomatic category is number one, which in India we find very few, because people, they don't undertake screening test as advised by the physicians. Then second category, which comes into my mind when we talk about the symptomatology of colorectal cancer. So for the general public, you should know that as we have left and right hand, we have the right and left colon. So the colorectum area is the area of the terminal area of your intestine. So we have food pipe, stomach, then small intestine, then large intestine, and then the exit part, that is the rectum. So colorectum is the part that is the terminal part of your alimentary system. So it is divided into left and right side. So if the cancer is of left side, it usually present with the change in bowel habits, that is constipation. So most commonly patients, they start to have some kind of constipation, and this constipation happens because on the left side of the colon, the food is in the solid form, while the right sided of the colorectal cancers, they present with bleeding. So these are two most important signs and symptoms, that is change in bowel habit, bleeding, if the patient is having any kind of colorectal cancer. People, they come to us and they say that, sir, हमें तो कभी pain ही नहीं हुआ, आज तक दर्द ही नहीं हुआ. So I can tell you that pain is not a symptom of colorectal cancer. It happens very late in the disease. Once the disease has progressed, it has gone to the lymph nodes, it has spread to the liver, then it causes pain. Otherwise, it doesn't cause pain. These are the two usual symptoms. Then few of the patients, they present with the emergency situations also. So they can present with emergency bowel perforation, so rupture of the intestine, or they can present with obstruction. So these are the symptoms which they present in the emergency condition. Few of the patients, they will have just anemia, nothing else. They are going to this physician just for a routine checkup, and they find that the hemoglobin is less, and it is the iron deficiency anemia which they usually present with. So these are mainly 3-4 different kind of presentation which we find in colorectal cancers.
Yes, thank you, sir, for elaborating so well. Like you rightly said, the crux of the problem is that cancer is largely a silent disease, not just colorectal cancer for that matter. Pain generally occurs very late, and by that time, it has already, it is most of the cancers are in the advanced stages by the
Yeah.
time
So
somebody
many, many,
experiences pain.
many times the general public comes to us and they have a
Yes.
lump in the breast and then
Right,
the lump in
right,
the neck. They think that
right.
is not troubling them. And similar thing happens with the colorectal cancer. It doesn't produce
Yes.
pain early in the disease.
Yes, yes. Uh, and thanks for nicely elaborating the difference between the symptoms on the right side and the left side, very elaborately and very correctly done. So you mentioned about screening at the beginning, of this discussion. So just to give a brief idea about the importance of screening to the general public. So colorectal cancer is a largely screenable cancer. So it is, in a way, it is fortunate that it is screenable, because there are only so many cancers, only few cancers, breast, colorectal, cervix, prostate, for which actually screening is available. So what why should we do early screening, or why should we do screening at all? Because I'll tell you, it can accomplish twin goals of prevention and cure. Not just one, because like Dr. Manish has alluded to this topic, that the colorectal cancer doesn't, I mean, sometimes it can occur just de novo, but most of the time it starts with a small polyp, and then which is not malignant, but which we call as pre-cancerous or pre-malignant, and then gradually it becomes cancer, invasive cancer, and then gradually it spreads to other organs. Now, what screening does is it detects the cancer before it becomes a cancer. It detects those polyps, and at the same sitting, the polyp can be removed. So basically, we nip the cancer in the bud, so to say. So that is the advantage of screening. And also, uh, if at all it has already become cancer, it will be diagnosed at a very, very early stage. Now, in any cancer, as a thumb rule, early diagnosis is the key to cure. It is not only from the health perspective, it is not only from the perspective of life, it is also cost effective. The removing a polyp hardly costs anything, and early diagnosis means less treatment. You can just get away with the surgery. There is no need to do chemotherapy. It will not only save people from side effects of treatment, it will also save people from the cost of treatment. It will increase the lifespan, it will increase the chances of cure. So all these are advantages of screening. Now, how to screen? Now, when I talk about screening, see, we generally have to categorize people into two categories: average risk and high risk. So when I say average risk, I'm talking about the general population. Okay, somebody who is, say, more than or equal to 45 years of age, somebody who has no family history, or in some cases, some family history, the particular, you can always check with your doctor if a certain family history, see, if a third cousin has got a colorectal cancer, that might just be a random coincidence. It might not be related. But more or less, if there is there is no strong family history, there is no personal history. Somebody who already has had colorectal cancer, or already has had a polyp removed, somebody who does not have IBD or inflammatory bowel disease, like I alluded to before. So this basically constitutes the average risk individual. So average risk, we have a few modalities. They can either do a colonoscopy once every 10 years, or a flexible sigmoidoscopy every 5 to 10 years, something called a CT colonography, which is basically a CT scan, a high-end CT scan, every 5 years, or a stool test annually. The stool test can be either the conventional guaiac based, or nowadays we also have DNA based stool test. So these are the different modalities. Now, even though we have so many modalities, I must emphasize that it is the colonoscopy and the sigmoidoscopy which has been found to be most sensitive, and these are the tests which will be necessary to kind of remove the polyp if a polyp is found. So these are the gold standard. The colonoscopy is the gold standard. Now, for higher risk individual, somebody who has a known familial history, known familial genetic syndrome like I described before, somebody who has IBD, somebody who has had colon cancer in the beginning, or who has had a polyp or pre-cancerous polyp removed, those individuals may need to do the screening more frequently, and they have to start at a younger age. The general rule is that we should start at least 10 years, either at 40 years or 10 years before the earliest case in the family. It's 10 years younger than the youngest case in the family. So that is the general rule. Now, Dr. Manish, can you just, describe what are the challenges you face when you counsel people for screening, especially in India? And what do you think, what are the advancements we have made as a nation with regards to screening in cancer in general and colorectal cancer in particular? Can you just, give a brief outline regarding these things?
So you very nicely spoke about screening. So just for the perspective of general public, let me tell that the screening means that you are just screening your body when it has no disease. So you take your car to the garage, even though it has no breakdowns, just to screen that car does not have any breakdown. So screening means that you does not have any disease, you don't have any disease, and we are just putting on some test which will detect cancer if it is present early. So we are fortunate enough to know that a colorectal cancer takes at least 10 years to develop. So similar thing happens with the cervical cancer, similar thing happens with the breast cancer, but it doesn't happen with other cancers such as pancreatic cancer or gallbladder cancer. So why the screening is available only for colorectal cancers, breast cancer and cervical cancer, not for pancreatic cancer? Because colorectal cancers, you can be saved. You can detect early, and the number of lives they are saved. So it is very important that screening, as you mentioned, should be done for all the people which are having a risk. So in general, you start screening at the age of 45. So earlier we used to screen starting from the age of 50 years, but now we have started screening from age of 45, because as we mentioned earlier in our talk also, that we are seeing more and more younger patients nowadays. And as you rightly said, different kind of methods which are available is colonoscopy and stool tests. So various stool tests they are available. Then high-end CT scans such as CT colonography, which can screen whole of your colon, are available and detect this polyp or the precancerous lesion early. So I must admit that screening does not provide you, or is not always good. So you have to be risk assessed appropriately, because it the screening comes with few of the harms as well. So just let me elucidate that the colonoscopy can have the procedure can have perforation, right? It can have some side effects. If you're going to be screened by the help of some stool testing like fecal occult blood or DNA based test, it can have false positive or false negative. So you have to discuss this thing with your doctors. It is very important whenever you're taking a screening test, what are the further things we are going to do. So if you have a fecal occult blood positive, it can be a false positive fecal occult blood, then you have to undergo colonoscopy, because it is standard of care once you find blood in the stool. So this has to be discussed very very clearly with the patients, and patients should know what would be the outcome like. Regarding you asked that the challenges about screening in Indian population. So I think the awareness is a problem. So not only the patients, but the general physicians or family physicians, they are not aware of that we can screen colorectal cancer. They are
Right.
aware that they can screen cervical cancer or they can screen breast cancer, but I can tell you that general physicians also are not aware that they can screen colorectal cancer. Secondly, once we talk about the colonoscopy for a young fit person individual, since this is an invasive test, most of the patients they will say no about that, and taking a CT scan, CT colonography would cost you a good amount of money, and the cost is definitely an issue. So I can tell you that uh, I am able to convince those patients who belong to metros because they can afford that. Colonoscopy, CT scans, they are available. But if you talk about the rural population, they don't have access to colonoscopy or they don't have access um, uh, to CT scans also. The blood, the fecal test, they were not of very good quality earlier, but the good quality fecal test they are available now. They are sometimes false positives or false negatives. Just I can just elucidate that when you're ordering a 𝐂𝐲𝐋 fecal occult blood testing, it can have false negativity if you're taking vitamin C tablets or if you are taking citrus fruits. Similarly, if you are taking FIT, that is fecal immunochemical test, then you have to stop the iron tablets. It can You have to stop a plethora of things before you take those tests because it can have some false negative and false positivity. So the penetration of these tests, it is not available for rural population as such. Even in metros, the testing is available, but the patients they are not they don't get very much convinced until unless they have good amount of family history. So we talking about the average risk people, they don't get convinced very easily because they just say, why should we undergo invasive test when we don't have that? But if the person is a patient is one from who has first degree or second degree relative, they get easily convinced with the testing. More importantly, other challenge which we find is there is no government policy as such on screening
Right.
as far as India is concerned. So we
Right.
have adopted all these screening strategies from the Western nation. We don't have any budget for screening in our Indian patients.
Very rightly pointed out a lot of points. Firstly, it is very difficult to convince the general pop. First of all, doctors, family physicians need to be aware that
Right. So
these are
family
the
physicians
screening.
are also not aware about the screening of
Yes,
colorectal
yes,
cancer.
yes. So education, creating awareness, platforms such as this, they will go a long way. Government policies, and not just government policies, I think even non-governmental organizations, voluntary organizations, or even, like you said, at least in urban centers, we have corporates. I mean, corporates can encourage or facilitate screening for their employees, not just for colorectal cancer, even for breast cancers. Breast cancer is relatively Screening for breast cancer is relatively harmless compared to colorectal cancer. It's just a mammogram. So I think, yeah, as a country, I think we need to look into this because that will actually save a lot of burden on the health system. It will, I mean, on the government health system, and it will also save lives, and it will also reduce the cost of treatment later. So I think we should all look into all these things. And like you rightly said, the catch of the stool test is that, after listening to this, someone should not just randomly go and do a fecal occult blood test. I mean, it's very necessary that you consult your doctor and ask them what are the things I should avoid, whether, there are some foods which you need to avoid before you do the test, before you give your sample. So you should be aware of all this, what can cause false positive, false negative. And as a general rule, I think if somebody has anemia, I think we read about this even during our MBBS times, but most people, most doctors, in fact, do not really recall this, that any male with anemia, with unexplained anemia, any male or a postmenopausal female with unexplained anemia should ideally undergo a colonoscopy. That is one
It is
point. Yeah.
extremely uncommon in a young adult to have iron deficiency anemia. You are very right
Right,
about that.
right, 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 right. So, Moving on to the staging of colorectal cancer. I know always after the diagnosis, the first things patient ask in our clinic is, "What is the stage, doctor? What is the stage?" Now, see, colorectal cancer, basically we use an international system. It is called TNM. So T stands for tumor, N stands for node, M stands for metastasis. So T, basically the tumor, what is the size and what is the penetration. So there are different layers in the intestine. So which layer has it penetrated? So that will tell you the T stage. It can be T1, 2, 3, 4. Then N stands for nodes. So the nodes are these are just structures which kind of drain something called the lymphatic system. So the cancer spread to the lymphatic system, and these nodes are the stations. So the nodes, whether the nodes are involved or not, will tell you the extent of the disease. And lastly, it is the M. M means metastasis, means whether it has spread to other organs. Now, based on the permutation combination of this T and M, we decide on the stage. So there are 4 stages: 1, 2, 3, 4. So basically, stage 1 and 2, it depends on the T stage, how far the tumor has penetrated. So when the nodes become positive, it becomes stage 3. And when the other organs are involved, when it has metastasized or spread to other organs, then it becomes M. And even among M, there are categories depending on which organ is involved, how many organs are involved. So basically, stage 1 and 2, highly curable, and most of the times only surgery may be sufficient. Sometimes in stage 2, some patients we may have to give chemotherapy. I'm talking about colon cancer. Rectum is a slightly different discussion. Stage 3 generally always involves chemotherapy. And in stage 4, in the advanced stage, most of the times it is incurable, but nowadays we have very advanced therapies, targeted therapies, immunotherapies. We'll come to that later. And if the number of metastases are limited, then sometimes we can even cure stage 4 disease in 20% or 20-25% of the times. So now basically like Dr. Manish said, in the West we have screening. They have regular screening. So the overall cure rate, it exceeds 70% for colorectal cancer. And in India, if you look at the statistics, it will not be even 50%. It will be somewhere between 40 to 50%. The main reason is that the delay in diagnosis. Now, there are infrastructural issues in the rural centers, but in most of the urban centers, in metros, in the cities, in the capitals, in India, we have all the infrastructure. We have all the specialists who can treat colorectal cancer. Currently, in 2022, I mean, all the metros, whether it's Delhi, whether it's Bengaluru, whether it's Chennai, Mumbai, there are so many centers which are totally equipped to give the same treatment you would get, in America or in London. So it is not the lack of facilities, it is sometimes the access to the healthcare facilities, as happens in rural areas, and most of the times it is lack of awareness and the delay in diagnosis. So the earlier we diagnose, the higher the chances of your cure. Now, Dr. Manish, can you just briefly describe the treatment methods which are available for colorectal cancer? Can you just specifically discuss about the chemotherapy and the radiation therapy with regard to
I would
colorectal
like to
cancer?
add one more thing to your discussion. You very nicely said that if it is early, it is always good. So many of the times we find our patients, they have been visiting their family physician with history of bleeding in stool, and the family physician would just say that it is piles and nothing else, and they would keep on lingering that it is piles and piles and piles, but in fact it is colorectal cancer which was there, and patient had reached the family physician early. So the physicians also, they have to keep the differential diagnosis of cancer up. So they usually keep their differential diagnosis of cancer below, in the fifth or sixth line, but they should keep differential diagnosis of cancer in the first line. So talking about the treatment part, so most of the colorectal cancers, if they are in early stage, the treatment is just the surgery which is needed. So the surgeon would remove the part of the intestine which is affected. Either it is right-sided colorectal cancer or it is left-sided colorectal cancer. In both of them, the initial treatment is just the surgery. As Dr. Kakoli mentioned, if the disease it has not spread to the lymph node. So once the surgery is done, this entire colon part which has been taken, it is seen by a pathologist under a microscope. So he's a pathologist who sees these uh, these tumors, and if it has not spread to the lymph nodes, it is an early stage disease, and most of the patients they will not need any kind of chemotherapy. But if it has reached lymph nodes, so this is called as node positive colorectal cancer, and in this case, the chemotherapy is needed. So chemotherapy sometimes amounts from 3 months to 6 months, depending upon what kind of risk assessment you are lying in. So if you have multiple lymph nodes, multiple adverse features, probably the doctor would give you around 12 cycles of chemotherapy. That is 6 months of chemotherapy. And if the risk factors they are not present, then it may be just 3 months of chemotherapy which the patient will need. The rectal cancers, as you mentioned, is slightly different. Most of the patients who have rectal cancer, they will need radiation, short course or long course of radiation. So radiation is not the one which we give in our home. So when we talk about radiation, patients think that it is just like radiation given at home. So it is not a radiation given at home. It is the radiation which is given by a machine which delivers electrons, and it is called a LINAC. The radiation is followed by some amount of chemotherapy, approximately 2 cycles or 4 cycles, and then surgeon operates upon the rectum, and then again some kind of chemotherapy is given. So this is the chemotherapy and surgical protocol and radiation protocol for colorectal cancer, which are early stage and which has not spread to liver or lung. If in case the disease it has spread to liver or lung, few of the patients they will still be in curative method. So the colorectal cancers, if the patient is fortunate, it has just gone to the liver, still these patients they do well, and the treatment remains surgery plus chemotherapy for these patients.
Right. Thanks for elaborating on it so beautifully. I mean, I think it's very clear to whoever is listening, to whoever is tuned in, that these are the treatment is available at most of the centers, like our center, like the center Dr. Manish works in, and it really depends on the stage. So early diagnosis, less treatment; late stage, more treatment; and very late stage, again, it might be difficult or sometimes impossible to cure. But even then, nowadays we are able to increase the survival. We are able to improve both the quantity and quality of life and maintain balance between the two. So that is something very important. And about the rectal cancer perspective, I think actually there are two things I wanted to bring forth. One is that, like Dr. Sharma said, that most of the times patients will be passing blood in stools, and family physician will be eluding it to piles, and the patient also will not take it forward. I mean, there is always an amount of optimism bias. There is always an amount of denial when it comes to cancer among the public, because it is a shattering, it is a very traumatic experience to be diagnosed with a cancer. We understand that, but the problem is that delay will only make things worse. Even if you're diagnosed at stage 1, you can lead an absolutely normal life after you finish your treatment. So that is something, the psychological perspective of it. So I think education awareness should also include that part, that denial is not going to solve it. So we have to take it forward, not just with regards to colorectal cancer, any health issue. And I think the pandemic has only made it worse. People who were doing regular screening before are probably, they have been hesitating for the last 2 years. So the pandemic will probably only add to the burden of late diagnosis and all these things. So there is one point which needs to be highlighted. And coming to the rectal cancer, the per se, so a lot of people, I think, among the general public, there is an idea that everybody will necessarily have to have a bag if you have a rectal cancer or if you have colorectal cancer. So that is so not true, especially nowadays. It's very, very rarely that somebody will need a permanent bag. Temporary it might be, but most of the times nowadays we have excellent techniques, we have excellent radiation techniques. We have, we have something called short course, even short course radiotherapy and things like that. So which really, these are organ preservation techniques. So when I say organ preservation, we mean the anal sphincter, so that patients can pass stool normally after the procedure. So these things have advanced rapidly. Very few patients actually need to have, and that is mostly in late stages and cancers which are very lower down. So most of the times people do not need a permanent colostomy bag. I think people should not be worried about that. You should just consult your oncologist and follow their advice and take
Here
treatment.
I would like to add one thing, Dr. Kakoli, that you are very right that we now have robotic surgeries and very minimal invasive surgeries that the people they will not need bag. But I would reiterate that even if you have a bag, the life is normal. Don't worry about that. With bag, people they go to the America, they go to Britain, they go to
Right,
different kind of countries, right? So the
right,
life is absolutely normal even if you have a bag. But the life is very
right.
important.
Yes, no, no, जान है तो जहान है, तो
Right,
जान है
very,
तो
very.
जहान है. Yeah.
So with
So
bag,
and
you can just go anywhere you want to do.
yes, yes, yes. And about I just wanted to, because a lot of people now they have heard the word immunotherapy. So everybody asks about immunotherapy nowadays, especially in Bangalore. We have a very strong IT crowd. So they Google all kinds of stuff and they come with all the information. So about the immunotherapy perspective, so basically most of the immunotherapies, they are generally used in the late stages, in the advanced stages, in the incurable stage, stage 4. So there has been very, very rapid advancements in cancer in general, colorectal cancer in particular. We nowadays even people have suggested a molecular classification. So it has become so customized, so personalized, that we do genomic profiling, we do gene studies, and then we classify the cancers. That has still not been incorporated into our day-to-day clinical practice, but I think that day is not very far. So when I talk about immunotherapy, I think the word in colorectal cancer, it is more of targeted therapy, which I would like to say. So it's basically, it depends on what mutations the particular tumor have. So depending on these mutations, we can choose one agent along with the chemotherapy. So the chemotherapy will be the backbone of the treatment, and on top of that we add something called as a targeted agent, which can dramatically increase the survival even in the late stages. And we choose the particular, so there are different targeted drugs, we choose that based on the particular mutation. And also remember, in the beginning Dr. Sharma had alluded to the side of the tumor, which side, right side, left side. So that also plays a part in deciding what particular targeted drug. So targeted drug is more like a missile, so it will hit the target, it will not kill everybody, so it will just hit the target, so it will not hit the civilians, it will just hit the cancer. So that is what is targeted therapy. So if there is a particular genetic mutation, it's like a silver bullet, we target that. So generally, we do not give it alone. We give it in combination with chemotherapy, and that has significantly, and they have minimum side effects compared to chemotherapy, and that has led to increased survival, even among patients with stage 4 cancer who are not otherwise curable. Immunotherapy also, it is being used in very specific situations in colorectal cancer. There is something called MSI high. So so I will not go into the technical details of it, but it's generally further down the line. So it's basically targeted therapy that we are talking about. So this is just to give you an idea, a gist about the treatment in the advanced stages. Like I said, we are now able to maintain the quality along with the quantity. You should not think that oh, stage 4 हो गया तो अभी कुछ नहीं है, अभी तो हो गया, ऐसा नहीं है. In some cancers like colorectal cancer, even in stage 4, you can have a life. आप मतलब you can extend your life. आप बेटे की शादी करा सकता हो, आपका बेटा डिग्री लेके आ सकता है, नौकरी में डाल सकते हो. So it's always, The more life you get, the always better. But we have to make sure that the life, the quality is maintained. So that is the work of an oncologist. That is the role of a medical oncologist. They will ensure that you have a quantity and quality. So I mean, of course, there will be some side effects, but with this newer advances, we have tried to reduce the side effects to as much as possible, and at the same time extending your life. Now, actually, we have all discussed about the cure, about the treatment. Dr. Manish has wonderfully spoken about the chemotherapy, the radiotherapy. I mentioned about the targeted therapy and things like that. Now, how to prevent it? So, the old adage, prevention is better than cure. So, how do we prevent colorectal cancer? So, basically, I will just say few things. So, we have already emphasized it that colorectal cancer is a preventable, screenable, and curable cancer. So, all three. It is preventable, it is screenable, it is curable. Screening is, like I said, based on your risk, what kind of risk category you fall into. Screening is something which should be encouraged by government, non-government, corporates, in whatever way, to whatever extent it is possible. I understand there are lots of issues in rural areas, but at least in the urban areas, we can, in the cities, in corporates, we can always encourage screening. Like I said, screening will prevent cancer. It will also diagnose cancer early and render it curable. Then what can we do? Okay, so there is non-modifiable and non-modifiable. Non-modifiable means we cannot modify the genes we have, which we have inherited from our parents and grandparents and all that. Even though even that is being discussed, but generally, we cannot modify the genes. So for that, we have to do the screening. But 80% of the times, it is not related to genes. It is not a familial disease. It is a lifestyle disease. It is a random sporadic disease. So what can we do? There are 5 things which you can do. Okay. Number 1, quit smoking. Not just smoking. I think you should quit all forms of tobacco. That is something which I would strongly recommend. Number 2, limit the consumption of alcohol. Limit the consumption of alcohol. Number 3, exercise regularly. Now, I am not saying ki you go on a rigorous exercise regime, you go on a very strict diet. I'm not asking you to do that. Just 20 minutes of brisk walking every day, that is enough. 20 to 30 minutes of brisk walking. So maintain a healthy body weight. Try to maintain a healthy body weight. That is the 4th thing. And the 5th thing, a healthy diet. Now, when I say a healthy diet, again, I do not believe in extremes. Okay, I will not say that do not do this except smoking. Smoking, please do not do. That is very strict. Other than that, other things, moderation. Moderation is the key to everything. It is the key to a happy and healthy life in general. So when I say healthy diet, include more dietary fibers, include more fruits and vegetables, less of red meat and processed meat. I'm not saying you can't have. I'm not asking anybody to convert to vegetarianism. I'm just saying that lessen the amount and try to replace meat with fish. Fish is healthy. Fish, legumes, this is healthy. So that is what, I mean, just balance it out. So that basically is the idea of it. So these are the 5 things which will go a long way in reducing the risk of colorectal cancer. Now, I also want to ask Dr. Manish about his views on this, on prevention, and how important it is that people understand. So that all these things, because लोगों को लगता है lecture मार रहे हैं, but how important all these things are actually.
Actually, you rightly mentioned about various things with the help of which we can prevent the colorectal cancer. So there is a saying that genetic loads the gun, and then the environment triggers it. So it means that all of us have genes which can predispose us to cancer. We have all these genes. So genetic loads the trigger, the gun. So we have the bullet in us, and then these environmental factors, which you rightly mentioned, they will pull the trigger, and one of us can have cancer. So rightly said by you that modifiable and non-modifiable risk factors. So non-modifiable risk factors we cannot modify by ourselves. But uh, in addition to what you said about the dietary fibers, smoking and alcohol, which it is a strict no, it is easier said than done, but it has to be done, right? Those patients who have family history. So the one thing that you not mentioned about the family history and patients suffering from some genetic syndromes. So there is a term which in medical term which we call as prophylactic surgeries. So
Right.
even if you're a part of family which is carrying this genetic mutation, so genetic mutations are the mutation in the DNA. Your DNA is not working well, and your family is having cancer again and again and again. So the children, the adults of these families can have prophylactic surgeries for them, and believe me that it can reduce the risk of cancer. So one of the very important example in this regard I always quote is Mrs. Angelina Jolie. So she is a Hollywood actress
Right.
who got her breast removed just because she was a carrier of BRCA1 genetic mutation which she inherited from her mother. So this was not a cosmetic surgery. It was a prophylactic surgery which she underwent. So similar prophylactic surgeries they are available in colorectal prevention of colorectal cancers also, apart from what Dr. Kakoli very clearly mentioned. So I think the crux of the matter is that the early screening, going to the doctor is very important. Healthy diet, prevention of obesity, physical exercise. So obesity so if you prevent obesity, if you are having physical activity, it does not only prevent colorectal cancer. So it prevents gallbladder cancer, it prevents endometrial cancers, it prevents ovarian cancer, it prevents postmenopausal breast cancer also. So just a physical activity which can prevent all these cancers.
It also prevents heart attacks. So that's
Right, very
it,
very true. So
it actually it prevents heart attacks and strokes. So I mean,
right,
this we are not just we are either that we are not just lecturing about colorectal cancer because people may feel detached. क्या हमें नहीं होने वाला ये cancer.
very true.
It's not just
So
about
you
that.
stop
It
uh,
applies to everything.
everything, right?
These few things, the healthy lifestyle thing, this applies to everything. It even applies to diabetes,
So
it applies to BP,
tobacco
it applies
tobacco can cause 16 different kind of
16
diseases
types
in the
of
body.
cancer. Yeah. Yeah, not to
All
mention,
in
not to mention the asthma and, pulmonary other issues. I mean, smoking, you not only risk yourself, secondhand smoke, you can just harm your spouse, your kids, so your parents. So yeah, so smoking, that's not smoking. I understand. So smoking, I'm very strict. Other things, I always say moderation because I cannot. I mean, I cannot write force somebody to quit everything. So smoking is something which we need to quit. Even alcohol, you have to have limited consumption. So that's the thing. So most of the things. So basically, see the message for this. Once again, I really thank the organizers for this wonderful opportunity. It is always a pleasure to have such an interaction with another faculty and share our thoughts, share our views. And when we miss some point, the other one always promptly points it out. It's always a teamwork. Medical science at the end of the day is always a teamwork. It's so nice to have such a lively discussion. The message would be, what I have been saying: colorectal cancer is a largely preventable, screenable, curable cancer. uh, be on guard about the signs and symptoms which Dr. Sharma has pointed out. Assess your risk, assess your family's risk, and consult a doctor if you need to undergo any genetic testing to confirm if you have a risk and how frequently you should screen. Encourage screening. I mean, you try to undergo and encourage screening. Even as a society, I think we should start because we are developing as a country. We are, kind of the progressing. So in all aspects, educationally, financially, economically, as a society, we are becoming more and more progressive. So I think screening should slowly be incorporated into the healthcare of the population. So that is one thing. And if unfortunately someone is diagnosed with colorectal cancer, please do not worry. Most of the times it is curable if you take treatment correctly at a proper center. Most of the times it is curable. So yeah, Dr. Manish, I mean, your message for the day.
So you very nicely concluded our talk of the day, and this is a colorectal cancer month. We are creating awareness about the screening and what are the different modalities of treatment available. Screen early, detect early, cure early. So this is my message, and very nicely we have discussed about the different kind of the food habits and exercises schedule which we should be having. Thank you so much for having me here on this show.
Thank you, sir. Thank you.
Thank you to both our speakers for today. Thank you, Dr. Kakoli. Thank you, Dr. Manish, for so expertly leading the conversation and for presenting with us such a wealth of wisdom and knowledge on this topic for our viewers. I hope good awareness was generated in this regard. I would also like to thank all our viewers and our supporters for this event today. And in the end, I just end on stay happy, stay healthy, and stay informed. Thank you.
Thank
Thank you
you.
so much. Thank
Take
you.
care. Bye bye.